Mario, I think we should greet our participants.
Okay, then let's start the meeting. Less formal, because I would consider Raed, Roy as friends, and I can't see, but I guess Lucian from the ERCC is also attending. So anyhow, very big thanks to our speakers and their availability for the KnowEMS webinar on burns, which is an important topic. And for the audience, I have to say, it's not that common that you have a high politician, which is an expert as well. So thank you, Raed, speaking about your experiences on mass burns in Romania. Also to you, Roy, thank you very much for the contribution of WHO on short notice. I know you have been thrown into the webinar, but I'm very, very sure that you can contribute and give an in-depth knowledge from a WHO perspective on burns and how WHO is dealing with. Lucien, I can't see you. Hopefully you are there. Looking to the hub. Oh, it's Jonut. That's what I'm thought about, the head of. Excellent. Another friend, I have to say. Looking to the ERCC, and we all know the mechanism when it starts in Avenue Beaulieu with a single room and the duty officers. Now looking to the ERCC in DG ECHO as, I would say, the hub for the response coordination within the Union Civil Protection Mechanism. Also, very big thanks to you and your availability. I'm half Italian. I try to limit my words. Thank you very much, and I would give the floor first to Raed and to listen carefully about the experiences from Romania. Raed, the floor is yours.
Raed, if I just may.
Yes, thank you very much.
Raed, if I just may for a second. Thank you, everyone. Just for those of you who are not familiar with the KnowEMS. KnowEMS is a project funded by the European Commission Knowledge Network with the idea of sharing knowledge, share, grow, and connect and grow. That's the idea, and this is why we are here. Mass burns are a very rare phenomena nowadays. Globally, there are not enough burn units in any country in the world for a mass burns incident. This is why such an incident are such a challenge for all of us. And this is why we are so privileged to have here Dr. Arafat telling us about the experience of Romania dealing with such an event. Sorry, I did not present myself. My name is Chaim Rafalowski. I'm from Agenda Vidadom in Israel. We are the technical coordinator of KnowEMS. Mario represents Johanniter in Germany. They are the project coordinator. So the idea is that Dr. Arafat will present the Romanian experience. Then we will go to the ERCC and the role of the ERCC in coordinating a European response in such an incident. And then we'll go to Roy on behalf of the WHO to the more global MEDEVAC perception on these incidents. So without further ado, Dr. Arafat, I apologize. The floor is yours, please.
Thank you very much. And thank you for inviting me. And I'm happy to be part of this webinar and that we are working together on this issue. I want to echo what you said before, in that the fact that we have lack of capacity to deal with mass burns incidents. And this, we have seen it also during our major mass burn incident, which was in 2015, which I'll talk more about it. But also recently, last year, we had a second explosion on a fire where we had 38 firefighters with burns of various degrees, and we had to move some of them to other countries. And this is where we used the civil protection, the European civil protection, and we received places from several countries, but I will come back to this. I will share my screen, just if you can confirm to me if my screen is shared. Just a second, because can you see my screen?
No, we still see you.
No, not yet.
Here it shows me share the screen. I put yes. And when I want to confirm it,
Now
says
we can see your
you
full
can see
screen.
the screen.
Yeah, but not the presentation. Yeah, now please
you
enlarge. Yeah, exactly. Now we can see
Yes.
it well. Thank you.
Okay, so I will go through the steps we had during that fire, and what I want to say is fires usually, when they take place, there are several reasons for them, and the worst of it is that the most important reason for fires to take place most of the time is negligence and not respecting the law and the rules. And here you will see this is the party which was taking place. Okay. So, what did happen here? They used fireworks of high grades, which normally are meant only for outside. They used them inside the building, inside the club. The second thing is that this club was authorized by the authorities as a cafe bar for 80 people, but they were bringing in over 350 people inside. From what you see here, the entry is through a vehicle container and with doors that open outside when you go out, but inside they opened inside. This is very important because when people started pushing themselves towards the door, it was very hard to open them so that they go out. And there was an emergency exit which was closed by the owners with a chain, so that nobody can go in from this side, but they didn't think of the evacuation issue. So from here you can see the door closed and the situation. There were windows that they were all shut with bricks, so the windows were no more accessible. So only this door which was there and the main door. And when they used the fireworks, all this was lined with acoustic foam from polyurethane. And this was the thing which inflamed immediately and started producing toxic fumes. The people were panicked. They started pushing themselves. They started stampeding themselves. And it was very hard to go out. And this is how many of the people died inside, by stampeding and by being intoxicated by smoke. So at 22:32, the first call came to the fire department, to the 112 call center. And at 22:33, they sent the first vehicles there. At that time, they didn't realize how serious was the incident. So they sent 3 fire engines, 1 ladder truck, 1 first response ambulance, and this is from the fire department. And the ambulance service sent also 3 ambulances there. The first thing we observed is that that club, which was in an old factory, it had an address which was communicated to the fire service, but that address was a closed gate. No one could go through it. And they had to go around and go in a gang here inside. And this is one of the issues which delayed the intervention by nearly 2 to 3 minutes. Now, this here, what you see, the small place here, this is where most of the ambulances and all the emergency vehicles concentrated to evacuate and so on. Inside, we had more walking intervention people, not vehicles and so on. And this is logical because we needed to leave it also for the firefighters to enter and rescue and to go out with those who are inside and to, of course, put off the fire at the beginning. So between 22:43 after the first arrival and 22:46, there were 8 ambulances already there, 6 type B, 2 type C, 3 fire engines, 2 ladder trucks, 1 extrication truck, and 1 command vehicle. Here you can see those people in civilian. There was a maternity near, and they came out to help. The anesthesia department from there came out to help. Here you can see the fire department crews and the ambulance crews working on patients, trying to resuscitate and work on the scene. This is what you can see, the container I told you about and how the firefighters were going in. And this is the place where we created the depot for the dead, where we took all the dead people there so that they are identified and the police can work with them. By the time I arrived there, there were already 14 people in that place, young people dead because of the smoke and the fire. And by the time I left at the end of the intervention, we had 26 already there. The only death on the way or at the hospital in that night was 1 patient which arrived, as we know, dead on arrival, and that makes the first day, the first night with 27 deaths caused by this fire, 26 on the scene and 1 on arrival to the hospital. In 6 minutes after the fire department arrived, the fire was extinguished and the rescue operation started. And you can see here firefighters being organized by the commanders and going in to rescue people inside. It was very dangerous because nobody knew if the structures would hold or if they fall on the firefighters. So there was a good plan, who goes in, how they go with breathing apparatus and bringing up the persons inside. Many of the patients, as it happens in any disaster, went with their own vehicles. Burns patients are not like explosion victims. Explosion victims, they have fractures, they have different things that don't allow them to move, and you need to go and pick them up. Burns patients, even with 70 or 80% burns, in the first minutes they can walk. Many of them, they can take the vehicle, the car, or jump into a taxi and tell him, take me to the hospital. And this happened in that night, and it was unavoidable in a way. And here you can see the organization of the ambulances to evacuate. So they were put by the evacuation officer in a way that they can be charged through the gang you have seen before and sent to the hospital. The Ministry of Health ambulances, the fire department ambulances, all together. And these are what we call them the multi-casualty ambulances on the top right side, which can take 4 patients at the moment, which were also involved in this intervention. So by 22:55, 23 minutes, there were already 16 ambulances, 12 type B, 4 type C. Type C are with physicians, 6 fire engines, 3 extrication trucks, 2 ladder trucks, 1 heavy extrication truck, 57 firefighters and doctors and EMTs from the SMURT system, which works with the firefighters, and 25 ambulance personnel from the Ministry of Health. By 23:15, the number of ambulances involved became 42, and the number of personnel from the fire service 168, and from the medical sector that works with the fire service from the hospitals, and 56 from the ambulance personnel of the Ministry of Health. And you can see here 8 type C ambulances, 34 type B ambulances. By the end of the intervention, the total ambulances involved were, in fact, 51 type B, 29 from the fire department, 22 from the Ministry of Health. We had 10 type C, 2 of them had emergency physicians on them, and 8 of them had physicians with 6-month training in emergency response from the ambulance service. The 2 from the fire department were with emergency physicians coming from the hospitals. We had 3 multi-casualty transfer vehicles, 2 advanced medical posts, 1 on scene and 1 near the hospital, which received most of the patients that came on their feet and they needed logistical support, and the command vehicle. Now, this is where the patients were taken. And here, what I would want to underline, the first thing we did, because normally there are 2 hospitals which take burns. When I was informed by the fire chief about what is happening, and then by the doctor, my colleague who's responsible for the fire department ambulance service for the fort, the first thing I said, take patients to all emergency departments, not only to the 2 which are burn centers. And it was the best decision ever I could take, because we ended with 88 intubated patients out of 56 patients which were taken to the hospitals. Should they have concentrated the critical patients only in the 2 burn centers, the management of the airway, the intubation, if it was not done on scene and it needed to be done in the hospital, they wouldn't have had sufficient personnel just to do this in 2 hospitals. They needed to spread the patients to all the emergency departments. So we ended by sending the patients to 13 departments. As you see here, at 1:30, what we call the red plan was deactivated. The red plan is the plan we used, like in France, to mobilize extra resources to go to the incident. And all the 162 patients were transported and evacuated to the hospital, including those who went with their own vehicles. But this happened in 1 hour and 40 minutes. So in 1 hour and 40 minutes, we have evacuated the area, and the patients were already in the hospitals, with 88 needing ventilation and respiratory support. This is the hospital you can see, which the patients took their vehicles and went there. Many of those doctors and nurses were ready to go out, so only part of them went out and part had to stay there until their colleagues arrived from home to deal with the patients who arrived. They received 57 patients to that emergency department, 57 burns patients to this emergency department. And of course, we will see what we did in the next step. So the next step was, after we knew the number of intubated patients, and with the Minister of Health, I was requesting him to identify equipment from hospitals that are not emergency hospitals and cannot deal with the burns, to identify extra ventilators, extra equipment, so that we can take them to the hospitals which will deal with these patients in the first step. So with the fire department, parallel with the intervention, we were sending trucks to pick up ventilators and so on and take them to the hospitals that will be dealing with those patients. So the next step was, from the hospital where many of the patients went to also voluntarily by their own, they were re-triaged and they were sent to 4 other hospitals, partially of course, and part of them remained in this hospital. And then there was 1 hospital which they dealt very well with 3 patients, but those 3 patients couldn't stay there. They had no surgery, no plastic surgery. They had only the intensive care and dealing with more chronic cases. So after stabilizing the patients, we moved them to other hospitals, to the military hospital and to 1 more hospital in Bucharest. So that was the second step, where we reorganized where the patients will stay. Now, the impact of this on our staff was huge. Here you will see one of our staff who worked on the hotline, which was activated. She remembered every name she was asked about. She was giving an interview here, and she was naming the patients. This is a physician who was working in the center. The same thing. They were very marked by what happened. So the third phase had to start, and the third phase was to try to send patients outside. At that time, the ERCC was not dealing with this type of cases, and we didn't activate the European Civil Protection Mechanism. After also I had a discussion with someone from there to see what can be offered, but there was no mechanism for burns patients and so on in 2015. We created it later, and we used it during our last fire, explosion, which impacted the firefighters. But here we worked bilaterally, and we talked to different countries which offered to take patients. So the military hospital in Brussels was the first to come and say, we will take patients, but we want to send our team to see whom we are going to take. They were mandated by the Netherlands to do this also for the Netherlands. We had people coming from UK, from Germany, and from Norway, and they came to see patients to see what they can take and treat in their country. So the decision on whom we send out was taken, in fact, together with those who will receive the patients. I will come back on this issue just later on our experience with the media and the attacks we had during this. But here you can see we used Ministry of Interior airplanes, we used Ministry of Defense airplanes, and we used NATO airplane also for the evacuation. And here is one of our old Ministry of Interior airplanes where it can take one critical patient. And they were sent to Austria or to Belgium or to many countries, as I said. And Israel also received 3 patients that were picked up by a private jet airplane ordered by one of the employers. So 3 patients also arrived to Israel from the patients that were in this fire. And here you can see the other, this is the military, the C-27J. That airplane left, the first 2 airplanes left, one with 8 patients, one with 9 patients. The one with 8 patients had 3 intubated and 5 non-intubated based on the selection that was made by our colleagues from Belgium. The one for the Netherlands, 4 intubated and 5 non-intubated. And here you can see the NATO airplane, which we used for long distance because we had to go to the UK and Norway, and the military airplanes could have made about 4.5 hours to 5 hours. So we called on the C-17, which is based in Hungary, because it goes in nearly 3 hours. It's in the UK. So we preferred this together with our Air Force to do it using this airplane. This airplane was supposed to take 12 patients. 2 were counter-mandated at that night by our teams. They said that there are 2 unstable to be taken, but 10 were taken, out of which 7 were intubated and ventilated. We had to bring a team of doctors and nurses from outside Bucharest. In fact, what we did, we sent a military airplane to the middle of the country. We picked up doctors from Cluj and Târgu Mureș with their equipment and everything. We brought them back, and we equipped this airplane, and then we sent the patients out because the doctors in Bucharest were already too busy and too tired of what they did until then. So it was a huge mobilization at the national level, and of course international level. So attacks on us started from the first night. An NGO started attacking. Why don't you take all patients out? Romania is not ready to take care of them, and we need to take all the patients out immediately. As much as we explained that you cannot transfer patients immediately because you need approvals, You need hospitals that have place to tell you that they have place for them and to accept them. And here the decision was that they come and they select, and that was a very wise decision. Otherwise, we would have been accused that we cherry-picked patients based on other criteria. So this was a very good step that we had them involved in this. And then we took testimonials. And here you have the first one. Do you hear the film?
Dr. Arafat, the colleagues say that there is no sound on the video. I cannot hear it either.
Yeah, this is weird because the film here, I hear it usually, it was no problem. Even now, they don't have the sound. Okay, the idea of those two films was that both physicians, Dr. Sarah Pape and Dr. Jeunesse from Belgium, Dr. Sarah Pape from the UK, both of them, they explained the decisions on transfer. When do you do the transfer? How do you do it? When you refuse transferring a patient, and when is the best time to transfer him? We were under very huge pressure, political and mediatic, and by certain NGOs, you will see this a little bit later, where they were insisting that we should have flown them in the same night out. And that was one of the major issues which went on for years to stigmatize us that we didn't do the proper work. But of course, it was impossible to move these patients out without approvals, especially because of what was said at the beginning, that there are no sufficient places in Europe even. We don't know where to take them. Burns patients cannot be taken just like this. You need to know that the country has the capacity to take them. And of course, every country will keep a capacity in case something happens there. So with the European Civil Protection Mechanism, the idea was that if we would have activated it, it would have done exactly at that time, exactly what we did to find some places for us, which we found the places. This is not a problem. The other thing they could help us with it is the transfer, but here we had our means of transfer using our airplanes and the NATO airplane. So we were not asking for transfer capabilities. And even this was an issue at that time in the EU. Now we are much better off with this. Here you can see the destinations of the patients. The yellow ones were transported privately, 3 to Israel, 1 to Germany, and all the red ones were transported by our means to the various countries. And here you can see the death graphic. The first day, and then we go the second, and here we had a huge number, 10. Most of them had airway burns, and they were in severe conditions, not only because of the burns, but also because of the associated trauma. And this is where one of the media outlets attacked a lot regarding infections, and they were saying that those patients died because of infections. Usually, in the first few days, it's hard to say that they died because of infections rather than they died because of their lesions, and especially the airway and lung lesions. Some of them were put on ECMO, and some of them survived and others no. So even ECMO was used on some of these patients. And one of the cases we had of a father saying that we refused transferring his kid out. In fact, his kid was on ECMO, and transferring him out would have been a major danger for him. And his big issue was his lungs, and he passed away even under ECMO. So explaining the medical issues to the lay people, especially in a very aggressive environment by certain NGOs, by certain politicians, was very hard, because anything we were saying was under doubt. So the testimonials I've shown you before were very important for us, because they helped in making people understand that we were not lying to them. And here you can see the deaths after that. The total deaths in this fire went up to 64, and some of them passed away much later, as you see. It was in October, and the last death was in March connected to this. So looking at the death rates in this, of those we transferred abroad, which had a lot of critical of them, among them 27.9%. Of those remaining in Romania, taking into consideration also that light cases remained in Romania, it was 22.01. So if we would adjust with the light injured people that were here and the critical who stayed here, we would see that at the end, there was not a very big difference. But of course, our capacity was very limited, and we had to send patients out, and we couldn't deal with them. We all agreed that we had to send patients out. Now, a lot on the media issue, the lies, and this is in our days becoming very important. Any major incident draws on it fake news, draws on it attacks. Political parties start fighting through the emergency situation. And here the first lies appeared in the first 30 minutes. And we immediately responded. They were saying that we arrived too late, which was not right, but they were using photos from the interior of that courtyard, not from outside. And as I said, the ambulances were out, they were not inside, because they would have blocked the area. And then we had a very interesting lie, which kept on going for a while, that the government hid the dead people to show them later slowly, because we didn't want to say really the big number of the dead that we had, and that we are hiding the real number. This has something behind it. And this didn't come from bad or suspicious outlets. This came from mainstream media people, but which are politically involved. And the idea is, from this, in Romania, in Israel, if you say this, people, they will say, you are stupid. How can you do this? Or in Germany and so on. In Romania, they were calling on the subconscious of the population, because this is what happened during the change of regime in 1989. The communist regime hid the bodies. So they tried to reactivate that consciousness and saying, yes, it happened once, they are doing it again. So we had to explain a lot, and asking them, okay, if we are hiding the dead, where are their families? Where are their friends? If we are hiding the dead, they should be coming and asking us about their friends and so on, that they are disappeared. So this issue went on for a lot of period. And here, one of the things that I accepted doing only a few days after, though my staff advised me not to do, is to go on an open debate with the most vocal person against us, and to do it in front of a lot of people who were in that fire and who survived without having severe lesions. And you will see that at the beginning, I was not even let talk, and then the microphone was just, they took hers and they put one so that who is talking will not talk over the other. Nobody will talk over him. But here the discussions and the debate went for 3 hours and a half. I will put very short sequence of it, but it went for 3 hours and a half, and that was a very, very tense one. After putting the testimonials and after coming with arguments, this lady left without saying goodbye to anyone in the room. And I think that this was the right way of doing it. We have to confront these issues and to explain what we are doing, because disasters always will bring criticism. So this NGO later obtained a lot of money, pretending that they are dealing with the burnt patients. And it was also a political involvement by them. It was not an NGO which was completely disinterested. But these things appeared only later and later. And the issue is that they harmed our services a lot. And it is an NGO which was dealing with cancer patients, but they found the opportunity to start dealing with burns patients, at least from political point of view from their side. So these continued appearing, these lies and so on. And of course, to go further, I'm not going to stop on the other incidents we had. Just 1 second. So from the lessons learned in this fire is the dispatch issue first. How do you dispatch and how do you anticipate? Now we insist, and there are procedures already from what we learned from this incident, is to send a higher number of force, even if you are not sure, and then you retrieve them if you don't need them, rather than waiting for someone to confirm to you that this is something serious. So this has been worked out with everyone. The other thing is that on that time, the dispatch of the Bucharest ambulance service of the Ministry of Health was totally separate from the dispatch of the fire service, which also had medical ambulances under it. But the idea is that there was a total desynchronization between the two dispatches. The chief of the Bucharest ambulance service was not in the country, but she was trying to lead her service from outside Romania, which was very hard. And of course, at the end, we were controlling the whole thing, but it created a lot of issues. Now, after this lesson identified, now the Bucharest dispatch has everyone in one place. They are all together. The fire medical people, the ambulance people, the 112 call takers, they are all in the same room. And there are liaison officers from the police and from the gendarmerie. So in other situations, now the management is done in a very much integrated manner. And then this is the new dispatch, which is now functional. As I said, we had a lot of resistance. Normally, we should have moved into it in 2016, and the move was done forced by the Department for Emergency Situations in 2018. And so that you understand our system, for those who don't know it, since 2014, we have what we call the Department for Emergency Situations at the Ministry of Interior, which coordinates all emergency response services, including those of the Ministry of Health. So from operational point of view, they are coordinated by us for daily and for disaster response. And this is very important, not only for disaster response, but also for the daily response, so that we know what is happening in the system all the time. Then, of course, the emergency departments, they needed more stockpiling. They needed procedure for transfer patients between hospitals to be better, because the huge number of patients that needed immediate reorganization was not easily implemented at that time because of lack of certain procedures. And this was worked on also. But they need backups, they need redundancies, they need space that they can open and they can fill up with extra patients if a disaster happens. There is no choice for this. You cannot shut your door and say, divert ambulances because I have no more space. If you are the only emergency department in the city, or if there are 4 or 5 and they are all full, you cannot leave patients in the streets. You have to take them. If you have to take them, then you have to be ready for this. And this is where, not only for burns patients, but also for trauma and other types of cases, we need to think of how we can very fast expand the space we work in case of a disaster. Then, of course, transferring patients abroad. At that time, it was the first time that we do something like this, and there was not much experience in this. The Nordic countries, all the Nordic countries together, they worked on creating a mechanism between them after seeing what happened in Romania. And they also talked to us. I visited them and talked to them about all the issues in detail that we faced. And of course, the ERCC, the European Civil Protection Mechanism, started discussing on how to do this in a better way. What blocked us at the level of the EU and stopped the procedure at a certain level, it didn't continue as I would have loved seeing it continuing, is when money comes into the issue. What we needed is that if you request the support, it means implicitly that you guarantee that the payments will be done to the hospitals receiving the patients, but the people dealing with health and with what we call social issues and disbursement and so on, they didn't agree on this, and they wanted more elaborate ways about payment, and that you cannot do this way, and it was a lot of legal issues to be discussed. But at least in the last transfers, this was not an issue. When we received for the firefighters from the EU Civil Protection Mechanism about 57 places in the EU, and we needed only 12, no one put this issue in the front line, and they said, okay, we will manage about this, bring the patients in, let them have their formulary of payment, and then we will discuss it later. And this is what happened with those patients. Difficulty to communicate with the families and the victims, because the families were already taken exactly by that NGO, and they were already mounted against the authorities. Though we discussed with them, they believed more what was said by the NGO than what was said by the authorities. So the cooperation with the NGOs, which we believe that this is extremely important. Our department has a lot of agreements with them, but now we sign agreements before, and we say that we will work with those with whom we have agreements, and and those whom we know, and we know what they are doing. And we won't work with NGOs that just pop up during the disaster and say we want to work, and we don't know what they can and what are their capabilities. We had involved non-governmental representatives in our crisis cell in my office working on this issue. And they knew very well the work that was done. The first 3 days, 3 nights, we didn't sleep at all. We worked to find solutions and so on. And with all this, this is what happened. So I will stop the sharing just to say a few words before I end. Okay, now stop the sharing. So the conclusion that I want to say is that such situations may put on the knees any system in the world. Any system can be challenged in any country, and not only in the pre-hospital, but also in the emergency departments. And not only there, but also in the intensive care departments. So if we want to be resilient, if we want to work and to be able to deal with such cases, we have to invest, we have to prepare, and we need to have the proper funding to be prepared, even if we will not use what we prepared for. What we call in resilience, the enemy of resilience is when people start talking about cost efficiency. They want an ambulance that is used 10 times per day. They want a bed that is full 90% of the time in the hospital. And this concept in the health sector doesn't allow us to prepare. I prefer to have 20% of the beds in the hospital empty, and to have more ambulances and more teams that are ready than having this at the level of the maximum capacity. And when we have a disaster, we cannot respond to it. To have possibilities to bring extra volunteers, to have possibilities to call on people. So these are all lessons we learned from this situation. And out of the things we are doing is extra intensive care capacities, like trucks that can host 12 beds of intensive care that can be put near a hospital and extend the hospital capability. And now we have containers. Each container contains the equipment of 15 intensive care beds without the beds, where you can go to a hospital and transform 15 normal beds into 15 intensive care beds. These are issues we have already, and we are building up as extra capabilities to support the emergency sector and the intensive care sector. I will stop here. If there are any questions, I'm happy to answer. Thank you.
Dr. Arafat, thank you very much for a remarkable presentation. In benefit of time, I would kindly ask for you to wait, if possible, to the end.
Yes, of course.
And I will ask our colleagues from the ERCC to present.
Hello, good morning, good afternoon, if that's the case. Can you hear me? Can you see me?
Loud and clear.
All right. Thanks, Dr. Arafat, for the presentation. I recall a lot from what you presented. My name is Ionuț Homag. I'm working in the ERCC, Emergency Response Coordination Center of the European Commission. I'm the team leader for operations for many years now. And in my presentation now, I want to make a little comparison. What Dr. Arafat presented 10 years ago, more or less, and where are we now? So please allow to share my screen. I do hope it will work. I have multiple screens, so can no.
The edit mode, Ionuț.
Okay, let me try again. Is it fine now?
You're not sharing, at least on my device.
No, we cannot see the sharing, Ionuț.
Now it starts.
Let me try again.
Now it's okay. It's okay.
Now that's the right mode.
That's the right mode. All right, then let's go. So I'll talk about what happened in the last decade. There were many steps, not only in the dealing with the burns, but in many other aspects of preparing and respond to various type of disasters. We have developed procedures, including for burns, and we developed a lot of response capabilities. I'll present some of these, the two important types of response capacities that we have, the European Civil Protection Pool and the rescue. I will talk about the current operations. This is what I'm doing for Ukraine, Romania, and Armenia, and then a couple of words on the future, the ongoing work, and where we're heading, what's cooking for the moment. But 2 words on the steps that we took in this last decade. It's not necessarily the bullets in the chronological order, even though there is a time connection. So we have strengthened, upgraded our legal framework. Not sure how many of the colleagues connected are coming from governmental authorities, but our legal framework is a decision of the Council of the European Union and the Parliament, 1313, starting in 2013, but it has been upgraded several times since, and subsequent implementing acts that are saying how we do things. And of course, this is very important as there is an important budget attached to it. We started this in 2013 with a slightly different organization on the medical capabilities. Disasters like the earthquakes, deployments in, let's say, all over the world, Ebola, showed us the need to align the terminology and the quality with WHO, and that happened in 2014, 2015, when we aligned with the EMT, notably quality requirements. And that was also marked by the creation of a initiative at that time under Commissioner Stylianides of the European Medical Corps. And that incentivized the creation of many quality criteria and developments in the medical domain. On the burns, there was a lot of effort led by Romania and Norway that led 5 years later to a working document that was discussed in the Civil Protection Committee and in the Council Working Group for Civil Protection that I'll talk about later. So very important developments in the response capacities. At that time, we developed what we call the European Civil Protection Pool, or ECPP. This is where we wanted to have predictability in the response. And this is what Dr. Arafat also emphasized at that time. You have a situation, you need to have a plan, you need to know what you can count on. Ad hoc is always good, and I also like good surprises. But when we plan for something, I would like to know that there is a safety net. So this is what this pool was addressing: quality criteria and then commitment from the member states to support. Ebola put us into the MEDEVAC discussions, and in those times in Ebola West Africa, there was a very clear situation where health workers were not willing to go to West Africa to do their work because there was no mechanism to take them out. So this is when we joined forces with WHO, with other commission departments dealing with health issues called Santé, and we put together a procedure. We put behind that resources, and then the message was clear: health workers, go and do your work in West Africa on Ebola, because we have a plan, we have a system to take you out in case of need. So that was the SOP MEDEVAC for high infectious diseases. And later on, in the same format, tripartite, we have developed something for for COVID, so for viral respiratory symptoms. Operations put us in the situation where even the ECPP capacities were not sufficient, and we had several instances where requests for assistance remained unattended, and this is that marked the creation of another layer of our response capacities. We call that RESC-EU. And the major difference between RESC-EU and ECPP is that the ECPP relates to existing capacities in the member states, participating states, that benefiting from EU funding, they upgrade those capacities to meet the quality criteria, and they are committed in this pool for a number of years. So existing capacities. RESC-EU means new capacities, developed 100% with EU funding, hosted by member states. And there is another important difference on deployments. While here there is some predictability, the hosting member state can always say no or refuse the deployment. And this happens many times in forest fire situations when hosting countries, they have big fire danger, big fire risk at home. I cannot send my Canadaires because it's burning at home, which is quite understandable. And that's why we need to have additional resources. And rescue means that hosting countries have a greater responsibility to deploy. This is where the ERCC has what we call command and control over the rescue capacities. And this is both teams, but also in kind, stockpile. I'll detail that in let's say in the next slides. Couple of words on what we have on burns, and this is the fruit of many years of discussions and pioneering. But in 2020, there was a document that was approved in the Civil Protection Forums describing the problem, describing the necessary elements and guidelines for a burns plan at national level. It is important that each country has such plan, because planning is the key word here. It speaks about the advantages of having secondary assessments and supporting the affected nation with secondary assessments with the so-called burn assessment teams, or BAT, B-A-T, with a tentative composition, a deployment time frame, and we know that such operations should fit ideally in a 48-96 hours time window after the incident. So then such team should be able to deliver the results to the authorities in maximum 72 hours. And for that, you need to have all that set in place. And we also managed to put resources and conduct, if I'm not mistaken, 3 trainings for these teams. Each training had 4 or 5 countries involved. So we have some 10-15 national burns teams trained. That was, let's say, introduced into the existing UCPM training program, so funded by the EU and implemented by a specialized consortium. So you see, it's a lot of things that happened in the last decade, both on legal, procedural, but also from the resource point of view. So I like to say that we put resources behind our words. And that's very important in those situations. And let me give you the overview of the medical capabilities in those 2 types of response layers, the ECPP and RESC-EU. ECPP is very large. It has nearly a decade. It was in 2014 when first high-capacity pumping modules were registered in the ECPP. Now we have more than 130 response teams in that. What you see on the slide is only medical. And on that, we have criteria and quality requirements for these types that you see here in red, the MEDEVAC, medical teams, and so on. There is variable degrees of availability across Europe. In the past, some countries had response capacities, but then that commitment expired, because this is time dependent. You're committing your capacity for 3 years, for 5 years, depending on the level of funding. And compared with a decade ago, when the fire that Dr. Arafat mentioned happened, this is what we have now. So a number of medical teams, a number of medical evacuation capabilities. We have also, we know where we want to go, what we name as goals, capacity goals. How many types of capacities should EU have for certain types of disasters? So this is the goal, and this is the work in progress. Each capacity is first being offered, and there is a process that is called certification classification that takes some time, and after that capacities are registered in our system called CESIS. It's a system that we use for the coordination. So it's quite a lot of them, many of them in the making, that are undergoing various steps in the process. And you also see the types. Moving on RESC-EU, this is where the European Commission put close to 3 billion euros for RESC-EU. and almost half of this amount was on medical capacities. So as the ECPP rescue is looking at many types of response capacities, we started with aerial forest firefighting, and we also developed into shelter, into transport and logistics, into energy. COVID-19 pushed us to develop this part of medical capacities, and lately we also developed this part of CBRN capacities that are very much intertwined with the medical, because we have a lot of countermeasures, medication, vaccines for CBRN. So again, and this is the geographical distribution. 16 countries are hosting what we call stockpiles. These are physical stocks of ventilators, of monitors, of infusion pumps, of protective equipment, and so on. And I'm proud to say that at this stage, the EU has a reserve of more than 600 ventilators, including pediatric ventilators, more than 2,000 infusion pumps, monitor beds, patient monitors, and so on. So this is part of the preparedness of the EU. Details on the host countries: an impressive budget of 1.6 billion euros.
5 minutes, please.
Yes.
Thank
you. That has been put into that. Work ongoing on the emergency medical teams. That has various components combining 8 member and participating states. That also includes burn rapid response assessment teams. Various countries are taking the lead on various types that are composing this big project. And finally, medical evacuation, and what you see in the picture is, yes, it's a tangible product that is available for various types of medical evacuations, including burns. 2 words on operations. I guess many of you are aware of the continental, and I'm repeating, continental medical evacuation system that we put in place for Ukraine since April 2022. Figures speak for themselves about thousands of patients that have been transported through the system. And that involves, let's say, careful coordination between affected country, ERCC, a medical evacuation hub situated in Poland, and a number of hosting countries for medical beds, but also for transport. What you have now on the screen is a zoom in for burns patients. Out of those thousands of requests, we also had burns patients that have been transported to 11 countries. The majority of them are military, but we also have civilians and children. We see an increasing trend in that, notably by the intensity of fightings that are taking place in the last months, year. The other much shorter event, but very intense, Romania, August last year. Dr. Arafat mentioned about that, but there was a request for 8 initially patients, which was upgraded to 18. And thanks to all the developments that I mentioned previously, Romania received offers for 53 hospital beds from all those countries. And finally, after a coordination and further medical assessment, what we executed, 12 patients transferred to the countries that you see on the screen. Some with Romanian means, some with other countries' means. The last operation pertaining to our discussion, a couple of months after Romania, Armenia, in the light of the Nagorno-Karabakh conflict, medical evacuation for burns patients. We had 18 at that time. Countries that you see on screen offered beds. Some offered transport, some offered only transport. And it was the ERCC that coordinated all that and put that all together. We had also a deployment of burns assessment team from Belgium that was very useful in that context. I don't enter into details, but the two cases, Romania very much knowing the procedures and so on, and Armenia not knowing the procedures, they have significant lessons learned on operations. What are we doing for the future? See, our society is changing. We have different crises. Ukraine, the conflict in Gaza with its own needs and difficulties, climate change. So we developed resilience goals, and these are the 5 ones that have been agreed only last year after a long process. And on that, we work on scenarios. So what we want is just to discuss what can happen, what is important for the union, how can the mechanism be challenged, and what are the aspects that we need to look into, including developing further capacities. These are the 10 scenarios that have been longly discussed and finally agreed. There is no particular medical scenario, but all of them, they have medical components. As people will get injured, people will get infected and will need to be evacuated, will need to be treated. So on all of those scenarios, we have also developed what we need to do. So we know that we need to develop further the medical teams in order to, like EMT1, in order to be able to attend up to 5 million of EU citizens, EMT2 up to 2 million of EU citizens. We need to have stockpiles that can go up to 500 million citizens. All that is the work in the making, and I'm happy to detail if there are questions for that. I will stop here, and if there are any questions available to answer. Back to you.
Thank you very much. I think this gives a very good overview about the umbrella that member states and associated countries have in the case of a disaster. And I will turn over to Roy to present the work that is being done in the WHO on MEDEVAC. Roy, please, floor is yours.
Thank you. Good morning, everyone. Let me start by sharing my screen. Can anyone please confirm that my screen is already shared? Yes? Okay.
Excellent.
Thank you. Thank you for the confirmation. And again, good morning, everyone. And my name is Dr. Roy Cosico, calling in from the EMT Secretariat based here at WHO headquarters in Geneva. And thank you for the opportunity of, thank you for the opportunity to for us to present on the current work done when it comes to the medical evacuation in emergencies. Well, the main purpose to have this document is for the provision of a framework for a context-adapted coordination, clinical care, operational support, logistics among the different medical teams that are operating and are wishing to operate in the medical evacuation space, with a definition or through defining the minimum standards and recommendations, the development of and classification of respective specialized care teams, providing medical evacuation or pre-hospital medical services. And with regards to the guidelines for medical evacuation is specifically referred to as a standardized process of any clinically coordinated inter-facility transfer of initially stabilized patients using dedicated medical transport platforms with specialized clinical staff, adequate equipment as we transfer the patient. Furthermore, this guidance document will complement and expand the guidance that is already provided in the Blue Book. At this point, you may have questions, although I'm sure everyone is very much aware of why this is important. And basically, it's from the lack of a standardized and common language to be used among all the medical teams, not just within the European Union, but even globally, as well as the lack of standardized tools. And as I've mentioned earlier, there's still no globally agreed medical evacuation standards. On the other hand, based on recent experiences of the different medical teams that have responded to such emergencies or that have provided response mechanisms, there have been different recommendations. And among them would be establishing rules, making algorithms, but also emphasizing the need for coordination. This slide briefly outlines the content of the medical evacuation document that is soon to be published. The tools have been developed taking into consideration the recent experiences of response or emergency responses in Ukraine, Armenia, Equatorial Guinea, and Sierra Leone, and which is also currently adapted for the Gaza context. And obviously, the contents of these documents are not coming from 1, 2, or even 5 people alone, but rather it is a pool of expertise from the different technical working group members from different medical teams who are considered to be experts in the field and with not just an academic background, but also solid deployment experiences to their credit. I've mentioned earlier regarding the need for coordination, because the coordination in an emergency response for medical evacuation considers a host of factors that would involve in the activation, the initiation, and confirmation of referrals, as well as the end-to-end patient transfer, or in the case of cross borders, the repatriation of the patients and even of their family members have also to be considered. But an effective response would require multiple elements which align with the requirements of a surge capacity. And this would include the team composition and not just the human resources, the availability of human resources, but also ensuring that they are adequately trained, and not just with the clinical functions, but also with the WASH, with IPC, with logistics, among others. And aside from the availability of the staff, this would also require the availability of equipment and consumables, the clinical protocols, and last but not the least, would be about the system for patient transfer. This slide this slide illustrates the setup of a surge coordination, or the EMTCC as we call it in the jargon, or the Emergency Medical Team Coordination Cell, with regards specifically to the medical evacuation. As mentioned earlier, we have signed SOPs with DG ECHO for the request for response capacities, including medical evacuation and the mobilization of experts. This has recently been successfully applied in Gaza with the deployment of more than 20 experts and still ongoing in support of the established coordination mechanism. The experts, among other tasks, have facilitated the identification of processes to support the medical evacuation, as well as working in liaison with the ERCC to facilitate the access to information member state offers, as well as understanding the current challenges. Please do not be overwhelmed with the texts in this slide. However, as I've mentioned earlier, coordination for medical evacuation considers multiple factors to become efficient. And from a bigger picture, there are multiple factors that are not as simple or straightforward as it seems. For instance, if we go to that green hexagon, which is about the transport provision, patient transfer does not, or patient transportation does not just equate with availability of a vehicle. There are other multiple factors to be considered, such as the presence of a local emergency medical service, or whether the emergency medical service is from a local level, a regional level, or as a national level. As mentioned by, let's say, by Dr. Arafat earlier, when it came to the response in Romania, there are different levels of emergency medical services providers. Another thing to be considered about here when it comes to the patient transfer provider would be about the type of organization, whether it be an NGO or a government civilian organization or a government military organization, vis-a-vis with the patient to be transferred. Because put into context, into the actual patient transfer, there would be certain instances when the patient to be transferred may not necessarily be aligned or, let's say, comfortable. The patient itself may not be comfortable to be transferred by the service provider. And another factor to be considered would be the capacity to transfer as well as the number of available assets. And last but not the least would be the level of care provided by the medical team, whether it needs or whether it meets the needs of the patient. An efficient medical evacuation goes beyond the availability of trained and properly equipped team members. And equally important would be the system or the how the patients will be transferred from one health facility to another. And people, let's say, as a team member, my experience, let's say, for medical evacuation may just seem to be knowing the phone number of the health facility where I will be transferring the patient and calling a focal point. On the other hand, beyond that phone call is a process flow. And the process flow in itself entails a lot of work, not just within the operations, but even works beforehand. Because obviously, during operations, it may seem a bit too late already if it would only be the time when a process or a system would be validated, would be undertaken, or would be even drafted. But rather, this is something that should have been in place already, even before at the onset of an emergency. Based on the minimum standards for medical evacuation or pre-hospital services being finalized. Yes?
5 minutes, please.
Yeah, sure. I only have like 2 or 3 slides left. A specialized care team can either be a basic or an advanced one. And the difference between the two would just be the capacity to transport and manage either a critical or non-critical patient. And some of the tools and processes currently under finalization by 2 technical working groups of the EMT Secretariat, namely the burn scare in mass casualty incidents and medical evacuation, were actually tested and applied during the response following an explosion of a fuel depot near Kankendi in Armenia, and as also mentioned by our colleague from the ERCC a while ago. And just for everyone's information, the burn scare in mass casualty incidents is expected to be published by the end of the 3rd quarter of this year, while that for medical evacuation is expected to be published by the end of the year. Now, in conclusion, with the objective of a common language and system, the tools, standards, and recommendations are proposed while emphasizing the need for a coordination mechanism and its activation. That's why, and that would be the end of my presentation. And on behalf of the EMT Secretariat, the EMT Initiative, and our network leader, Dr. Flavia Salio, thank you very much and good morning.
Thank you very much. Any questions? So I would take the prerogative and I would ask Dr. Arafat, with the wisdom of being a long time after, what would you have done differently on that night?
Well, I think that the work on the transfer of patients, the discussions with the hospitals should have been prepared before. So I would have prepared the mechanisms for this. And now this is happening through the ERCC. So now it is much easier. So the delays we may have had then until we got in contact and bilateral work, it could have been done much faster. This is one thing. The other thing is the command and control on the scene. We have seen certain issues which need to be improved and to be made better. And especially that the ambulances that are arriving, they were not all working exactly according to the rule, which means to do the triage and to take those who are more critical and so on. We had a few ambulances arriving, picking up patients and leaving with them without what we would call the procedure that we have. So we had to revisit this and see that this happens in the future much better. The other issue is about the involvement of the private ambulances. Our RED plan foresees that once we activate the RED plan, the private ambulances deal with the current cases, not with the disaster. And this, I think, is a good practice. The only thing is that we were attacked that we refused the private ambulances, which is it's very wrong, because we used them in the current emergencies, because we still were getting calls for chest pains, for other things and so on. Why did we do this? Because the private ambulances are not standardized with our ambulances. So it meant if we bring them there, their numbers is not high. It was not a big capacity, but bringing them there, you will have various standards whilst concentrating our own ambulances, the Ministry of Health and the Ministry of Interior, they are same standard, which makes it much easier to work on the field. The people know the equipment, they know how to work on them and so on, and they are used to work together. And this is why we decided to use the private ambulances only for the current cases. Much better recording of the hours, of the minutes, all the journal of the situation must be detailed, because what we found later is that we had to gather information from people because they didn't write them at that time. They forgot to write them at that time. And once you have prosecutors involved, you need to defend yourself very well. And you need to have a very clear register of what you did in such a case, in such an intervention. So this is another issue. Maybe we should have been also much more aggressive in communication. We were very busy in dealing with the situation for the first days. So we gave the opportunity to others to communicate publicly because they had time to go on TVs and so on and communicate. And with us, we communicated, but in my opinion, not sufficiently and not sufficiently as a modality of communication. So we need to look at much better communication. In the next disasters, we had disasters like the explosion we had with the fire department and so on. We were much more, I would say, early and aggressive in communication. When they started accusing us of certain things, we went immediately out and we responded. I will give you an example. They took a few helmets of the firefighters which were deformed, and they started saying that the quality of the material is bad, that everything is not good, that the equipment is not good. And on a direct interview, they showed us one of this, and we told them, did you ask the firefighter who was wearing it if his head remained intact or not? Because the task of the helmet is not to remain beautiful. The task of the helmet is to protect the head. and the firefighter had no problems, he was protected. So it was okay that the helmet was deformed, but the firefighter was protected. So such communication directly and debunking all these lies and so on needs to be done very early. Never allow them to do this and go later. It will be too late. So these are a few things that we learned from this, and that we would do them, and we are doing them already differently, because we already have 9 years since that incident. We had other incidents where we changed the way we work, and we learned certain things. And of course, the most important thing is unique command, single coordination, integrated approach. These are extremely important in such situations.
Dr. Arafat, thank you very much. I think we have time for 2 more questions, if there are any.
There are some
Please.
in the chat, Chaim.
Yes, please, Michelle, I cannot see the chat, so.
Oh, okay,
please.
sorry. So the first question is to Dr. Arafat, which asks, the Wikipedia entry to the burn incident mentions the poor quality of disinfection, like hexapharma used in Romanian healthcare providers, and therefore one important reason for more death. Is that so?
Well, this is a very, very, very good question. Wikipedia, first of all, we should understand who writes it. It is a pooling of public people writing it. So there are activists which also write there. The hexapharma story was the following. The journalists that made a target of this situation for weeks and months and years, maybe, even till today, who's a sports journalist, he came out with the following news. Hexapharma was delivering disinfectants which were diluted 4,000 times. And this is why we had hospital infections. This led to the suicide of the owner of the hexapharma. Big investigation. And now I put the first question, which I put it to everyone. What does he mean by 4,000 times diluted? This is homeopathy. This is no more. If a betadine is diluted 4,000 times, the color of it will be water. It will not be betadine. So that was exaggeration and lies. Yes, there was, the report said that there were certain components of those disinfectants which were diminished, but it depends on how long the surgeon would wash their hands. If they wash them 1 or 2 minutes more, then it is okay. There was a diminishing of the concentration, but the lies that were put around it and the lynching of the owner, it made the owner to kill himself. So, and until now, we didn't see a real conclusion of this story. That journalist was interviewed by other journalists, and one of his answers was that he believes that exaggeration is a way of journalism, and that if he exaggerates, he brings more attention to the subject. So he said it himself, that he is happy to lie and exaggerate in order to bring more attention to the subject. But sometimes the way you do it may have other consequences than the ones you want. Now, saying that because of that they had infections, that company was delivering not only to public hospitals, but also to private hospitals. We didn't see any scandal with the private hospitals. It was only with the public hospitals that were buying this type of disinfectants. And should it have been right, we should have had a lot of infections in the hospitals, not only with the burns, but with abdominal surgery, with thoracic surgery, with everything, which is not the case in this situation. So I think that the information was denaturated. There is some part of the truth in it, but the worst lie is the lie that has some truth in it. And this is the issue here. But the way it is presented, it is much out of the line, I would say.
Michelle, please choose one more question and we will
That's it. The other question was the QR code wasn't working from Roy's presentation, but he posted the link in the chat. So that's all questions we have.
So Mario, over to you. Mario, you're muted.
The famous final words. What should I say? I was, let's say, really addicted to listen to Raed, to Yonut, and also to Roy, where I see some of the, let's say, outcomes of the technical working group. Thank you very much for all of you. also to the audience to show the interest and for the valuable questions. And not only, let's say, let me a little bit advertise for the project itself. It's hard for us now to find speakers which are creating more interest in the upcoming webinars and find, let's say, more interesting topics which has been presented now. But please register in the network and follow us in the coming webinars. And I promise there will be additional interesting webinars. Raed, Jonut, Roy, many thanks again for your availability. As we usually all say in our community, stay safe and healthy, and hope to see you soon. Thank you very much.
And those who are joining us for the next discussion, which is starting in a minute, please join us there. And thank you again, and see you on our next webinar. So thank you very much.
Thank you.
Thank you.
Bye. Bye.